my personal experience is based how to know how the technology works and what are the needs of the technology to be effective. Because you can drive a Formula One car, but if your experience is not enough, you crash immediately. So what we need to think about is that this technology is very rare to adopt. 99% of the eye surgeons didn't face that in a significant number. And so there is no the perception how we need to manage this different situation. First of all, it's not only a problem of IOL technology. Yeah, the main revolution is that the technology is different and provide different outcomes. Correction-free vision. That means to drive a car and to read a newspaper with no correction. Also, if for your whole life you have experienced the necessity of a correction. But this is the result. We needed to learn how to adapt. We needed to take care of the quality of the tear film, because only a good tear film quality provides a smooth surface of the cornea, and that gives to the advanced technology the opportunity to apply perfectly the right measurement of the biometry. We have a technology that provides 1 micron precision, but if the surface that we get the shot is irregular, the outcome could be not perfect. Because our goal is, with this technology, also if they are different, to get plano result after the surgery. That means no residual refractive defect. This is the key, but this is a key that you can adopt and understand completely after a huge number of experience, but mainly to face the patient reaction and need before and after the surgery. Is very interesting, because this is a very old concept, the pinhole concept, that every eye doctor knows since 3,000 years ago, and so it's surprising how can be adopted in more advanced IOL technology. The concept is simple. The pinhole effect practically provides you the opportunity to manage corneal astigmatism up to 2 diopter without adopting toric IOL. And so, sometimes it's tricky, it's not really precise to organize the right axis. Sometimes the surgery is not easy, and so you have difficulties at the end of the surgery to put the IOL, the toric IOL, in the proper condition. Sometimes surgeons adopt different technology after cataract surgery to update this. So this is simple. Naturally is the first generation, and there are some weak points. For example, the size of incision is 3.75, and that is not effective. We need something better, because with this size of incision, we are inducing surgical astigmatism. It's the truth that the technology is take care of that, but naturally the perfect surgery need a smaller incision. The second advantage is that we know that 99% of the eye surgeons are not adopting presbyopic IOL because they fear the side effect of the technology. So this is something relaxing. Why? We put the technology only in one eye, in the non-dominant eye. And that works for the pinhole effect perfectly for near. So we are confident. But this is not monovision, because also with this lens, far distance is at least 0.9. So 0.9 is not monovision. But the main practical concept for the eye doctor is, okay, but in the dominant eye, the eye that is managing and controlling the quality of vision, overnight driving, is perfect, because what do you implant inside this eye? Do you implant the most advanced spheric monofocal IOL? So this patient never face a problem driving for glare or halos during night driving. And that is a key question. What fear the eye doctor in their office when they face a patient to complain? Doctor, I can't drive overnight. Yeah, was an approval study. Naturally, we have no experience, so we have theoretical experience and something coming from a small number of surgery in different countries where that is where possible. So we had to learn, as always, to avoid any weak point and to try to take the most important advantages. So my first perception was something strange, because one more time, the pinhole effect is something different. And normally, when I speak with my colleagues, well, they seem a little bit surprised about that. But to be practical, I have the opportunity to learn, understand why this technology should be effective and well understood. Because we have a perfect, we have tried a perfect goal. This technology is absolutely the best IOL technology to be implanted in eye after RK. RK in the United States and many countries is a huge problem, because that people that perform this surgery when they were 20 years old now are 70. And so naturally they face cataract. And you know that the main problem after RK is the fluctuation of the visual acuity and the refractive residual defect that normally is hyperopia and astigmatism. So the pinhole effect take care of that, but the large majority of the patient has a dramatical improvement. Due to this experience, this IOL is wider to implant a presbyopic IOL in patients after laser vision correction or LASIK. Why? Because naturally we are speaking about eye that present some aberration or some not perfect or little bit irregular cornea, and all this situation has a side effect. One more time, the simple concept of the pinhole overcomes the problem, and that is something unexpected but really practical. I know that a very few number of surgeons are performing cataract on RK patients, but this is a reality, and this is something that we need to manage. And finally, after a lot of years, this is something effective, efficient, and that create a very good will from the side from the patient.